I was born in Naperville and went to med school at Northwestern and have a lot of family
Oh,
and friends there. So I miss Chicago. What a great city, you know?
it is. It is. Come on back home anytime.
Yeah, miss Chi-Town. Good city. But I'm in Philly now. Not a
Oh,
It's gotten grown on me here. So yeah,
yes, yes. You're at UPenn, is that right?
that's right. Yeah.
So many great people there. It's
Yeah.
it's a great place. All
Yeah.
right, I'm actually gonna take my glasses off. And then what was I gonna say? I can't remember. Um, who knows? Oh, let me make sure I'm pronouncing your name right.
My full name is pronounced Nilanjan. Nandi.
Yes.
Nandi is the last name. Nilanjan is the
Mhm.
first name. But you can call me Neil. It's just fine.
Oh, okay. Well, do you go by Neil or is that just like,
I go by both, but for conversation, most of my friends just call me Neil or Hey You. But Hey You would be not professional enough for the program. So
hmm,
so but Nilan, you can introduce me as Nilanjan if you like, and then just call me
Nilanjan?
Neil the rest of the time, which is fine. Yeah.
Um, okay. And so the background is always this episode looks like I'm not half naked. Okay.
I was going to text you that because I didn't know how to verbalize that. Okay.
All
I'm
right.
going to go off camera. And Dr. Nandi, one thing I didn't tell you, if you make a mistake and want to re-record, I ask you to just give us a count to 2 to yourself, just to give us a clean break on the back end.
Sure.
Dr. Peak, when you're ready.
Okay.
Sherry, I think you have to start recording again.
Because it says it's recording on my side, you know.
Oh, and I see a little beeper that says this meeting is being recorded.
Yeah, it
Oh,
says
wait.
recording on my side.
Okay. We're just going to assume that we are. Hello, and welcome to a very special series I'm moderating on diversity, equity, and inclusivity by CME Outfitters. This is a CMEO briefcase called Take Action, Optimizing Equity in Gastroenterology Care. This program is supported by an educational grant provided by Johnson & Johnson. My name is Dr. Monica Peak, and I'm the Ellen H. Block Professor of Health Justice at the University of Chicago, where I also serve as the Vice Chair for Diversity, Equity, and Inclusion. I'm delighted. Let me just back up and I'll say what I want. I am a practicing internal medicine physician, as well as a health services researcher in health equity and a bioethicist. I've been practicing for about 20 years, and I really enjoy seeing the wide range of patients, including those who have gastrointestinal problems. And so I'm really delighted to be joined today by my very distinguished colleague, Dr. Nilanjan Nandi. Dr. Nandi, welcome to the program. And if you would please introduce yourself to the audience today.
Yes, thank you so much. I'm really pleased to be here. My name is Nilanjan Nandi. I'm an associate professor of clinical medicine at University of Pennsylvania, the Perelman School of Medicine, where I am blessed to specialize in the treatment and management of Crohn's and ulcerative colitis patients, collectively known as inflammatory bowel disease. I also happen to be one of the co-founders and chairman of the board for the South Asian IBD Alliance, also known as SIA, which is the first patient-physician collaborative and nonprofit dedicated to raising awareness and education and also accelerating research on IBD for all communities around the world.
That is wonderful. I was not aware of that. So we're extra especially wonderful. Let me say that again. So that's wonderful. I was not aware of that. So we are very additionally grateful for your presence today. So you're bringing not only your clinical expertise, but a lot of the additional knowledge that you have with working with patients, not only as people that you see as patients, but also as people in the community as they're able to advocate for the very diseases that you work on in a collaborative fashion. So we're really looking forward to our conversation today.
Thank you.
Before we begin, I just want to note that this program is designed to build upon foundational concepts that have already been covered in some of our previous DEI activity series, and to learn more about the impact of systemic racism on healthcare and on health disparities, as well as how racial and ethnic disparities may present in the field of gastroenterology. We encourage you to engage in these foundational programs, which are linked here. So before we begin, I also just want to clarify that Nilanjan and I decided that we refer to each other by our first names in order to keep this session more collegial and just informal and friendly. And so Nilanjan, I look forward to our case discussion and our very candid conversation today. I'm going to start by reviewing our first learning objective for our program, which is to implement strategies to address inequities in the treatment and outcomes of patients with GI disorders. And we'll be focusing again today on inflammatory bowel disease. And so I'd like to open the case first with I'll start again. And so I'd first like to open the case with a question for the audience. And so the question is, how confident are you in your ability to identify racial and ethnic disparities in the management of patients with gastrointestinal disorders? Either not at all confident, somewhat confident, confident, or extremely confident. And of course, your answers are anonymous and confidential. So please feel free to just honestly answer. It helps us as a program to have a sense of how things are going. And so to highlight some of the disparities in the diagnosis and management of patients with inflammatory bowel disease, or IBD, let's consider a case example. And so Nilanjan, would you mind presenting the case of Dhanraj, whose pronouns are he and him, to the audience today?
Absolutely. Thank you, Monica. So to our audience, we have a patient named Dhanraj, whose pronouns are he and him. So Dhanraj is a 38-year-old South Asian male who immigrated from India 3 years ago to the United States. His primary native language is Gujarati, and he's been experiencing, when he comes to the physician, describing rectal bleeding, bowel urgency, and increased stool frequency. He does have a history of hemorrhoids, he notes. He works at a very well-known tech company and is very thankful and humbled that he wasn't laid off on the recent rounds of layoffs because his visa is tied to his work. So this is obviously a stressor in his life. He's worried about his job because he frequently has to call out due to diarrhea, and he feels that his employer is already frustrated with his limited English proficiency. So, Dhanraj, I'm in here in the Northeast United States, here in Philadelphia. We have a large, information technology enterprise and network here. So, I've seen patients just like Dhanraj in my clinic. And, the first thing that strikes me here is young South Asian male, has a history of hemorrhoids, which we'll talk about has some stigma in the South Asian culture, in many cultures, right, Monica? So many people find this taboo.
Right.
And he's really stressed because he's having these really disconcerting symptoms of rectal bleeding, which might be rectal outlet bleeding just purely from hemorrhoids, but it's really concerning that he's got the bowel urgency. Hemorrhoids really don't cause bowel urgency. That urgency, that sense of incomplete defecation, that's concerning for tenesmus, that there might be some swelling or proctitis, and that might be something like ulcerative proctitis or Crohn's proctitis. Who knows? We're not quite into the diagnostic stage yet. And then you see that there's this work stressor and life stressor, right? He needs to provide, he's got a job, his visa and job are tied together, and he doesn't want to upset his employer by being ill. So he's in a desperate situation, and that's the first thing that I'm recognizing, that he's not here begrudgingly. He's really concerned about his symptoms.
Yeah, and I think it's important that you've highlighted many of the sociocultural ways and pressures that people may have that keep them from either addressing their symptoms or being able to bring their symptoms to medical care. So they may want to just, there may not be able to, for social reasons, to sort of acknowledge that they have them, or they may be under such pressures to stay at their job and to work and to, stay in this country and can't take time off work or whatever, that they can't actually make it to the doctor. And so these are issues that translate to so many communities, and particularly in gastroenterology, or which is similar to urology or to, women's health, where the area of concern is a sensitive area that has a lot of an additional layer of sensitivity around it. that we can see some additional disparities just because of where the symptoms are coming from.
100%. And I just want to highlight, what you said so important about the social pressures of not speaking up. In almost every culture, we can relate that everyone poops, but people don't talk about it, right? And that's changing with modern times. In South Asian culture and other cultures too, but South Asian culture I can speak for, people do not talk about their bowel habits. It's perceived as they don't talk about hemorrhoids. There's a shame in it. Although I'll tell you, as a gastroenterologist, I shine the light where the sun don't shine. Everybody has got hemorrhoids. Okay,
Mhm.
Monica, everybody's got hemorrhoids, whether they know it or not, whether they've bled or not. And
Right.
in
I
South
see
Asia,
the
they call
reports from the colonoscopies.
that's right. That's right. And in South Asian culture, they call it piles. It's something very stigmatized against in South Asian culture to even talk about blood and stool or that something might be going on down there. But the other stressor here, his job and his visa, just to emphasize that point, this is a South Asian male who may be like sending money back home to his family, right, to support them. So he critically doesn't want to lose the job. He needs to keep the job, needs to keep his employer happy. So he's here under desperate circumstances. But anyways, I'm glad he came, and hopefully we can get more into the details of how to diagnose and then hopefully help this young man.
Absolutely. So we're going to ask the audience another question before we move on. And that's the question is having to do with diagnoses. And so which of the following statements regarding disparities in inflammatory bowel disease is most accurate? That A, immigration status does not impact diagnosis of inflammatory bowel disease. B, patients born outside of the US are less likely to be diagnosed before the age of 16 than patients born inside the US. Or C, South Asian patients living in Western countries are at lower risk of all types of IBD. Or last, D, patients born outside the US and all underserved racial and ethnic groups are more likely to experience milder disease. And so for our audience, the answer is B. And so Nilanjan, would you mind just sort of walking through some of the information on disparities of diagnosis to highlight why this is the appropriate answer?
Absolutely. And, I like doing this type of, dissection of why these answers, some are right, some are wrong, because it
Yes.
really impacts a whole lot more information. And so, we have studies that have done through the last several decades looking at IBD outcomes, prevalence, and incidence, and how it's changed over the last several decades. A couple of those highlights are that South Asian IBD, whether it be at Crohn's or ulcerative colitis, appears to be increasing in prevalence globally. And we know this through natural history studies. They actually do flexible sigmoidoscopies door to door to door. And they did that in northern India a couple of decades ago, actually in the 90s. And then they repeated that study later. And they saw that while looking door to door to door, they saw there was actually increasing prevalence, particularly in westernized cities.
Mhm.
And we'll get more into why that may be. They've also looked at immigration pattern. When people from South Asia, migrate to the U.S. And to be clear, South Asia is actually 13 different countries beyond just India and Pakistan, but Bangladesh, Nepal, the Maldives, Sri Lanka, and more. There's almost 1.8 billion South Asians in the world, which is a significant
It's
chunk
a
of
lot
the
of
global
people.
population. And the prevalence of IBD in this community is estimated. It used to be estimated to be very low, but the studies are showing that in South Asian cultures and other ethnic minorities, that it's increasing. And in South Asian community, it seems to be almost on par as what we observe in European Caucasian populations here in the US.
Mhm.
So anywhere from a minimum of 0.7% to as much as 1.2%. So Monica, I mean, 0.7% of 1.8 billion,
It's a lot of people.
that's a lot of people. That's a lot of people. And that's also a lot of people who don't know that they're at risk for inflammatory bowel disease. And to compound things, the traditional teaching, how I was taught in medical school, was that South Asians wouldn't have IBD. They weren't at risk for IBD.
Mhm.
And I'll tell you, my own father was diagnosed with Crohn's in the 70s. It walked like a duck, quacked like a duck, but they said you can't have it because you're a South Asian male. And someone took a chance, gave him some steroids, and sure enough, boom, just like that, he got better. So my what I'm painting to our audience here is there is an increasing prevalence of IBD. patients are unaware that this exists because the symptoms can mimic so many other things.
Right.
And then clinicians, even South Asian clinicians, are maybe unaware that this prevalence is increasing. So with that framework in mind, now we look into the studies and they show that a couple of different highlights, right? Those individuals who are born outside of the US, for instance, in South Asia, they're less likely to be diagnosed with IBD before the age of 16 than patients born in the US. So if you're native born here in the United States of America, you're more likely to present with IBD at a younger age. But if you were born outside and then immigrated here, you're more likely to diagnose it later in life. Now, part of that might be due to what age you immigrated, but beyond that, it seems to be a later age of presentation. We actually see similar things in the Latinx community, where those immigrating outside of the country coming to the US are diagnosed 45 years and later, and those born, native born, are diagnosed in their teenage years, like 15, 16. Also, when we see patients who are born outside the US, they're more likely to be diagnosed with milder disease. And I'm going to put that in quotes because milder is a subjective thing.
Right.
Milder disease than severe disease, more likely to be diagnosed with ulcerative colitis compared to Crohn's. Although I'll get a little bit more detail there. When they're diagnosed with UC, it's more likely to be extensive pancolitis as opposed to proctitis. So although it may be in quotes mild by statistical demographics, there's more surface area involved. And that's a lot of colitis, and pancolitis usually behaves more worse than proctitis, right? And then when it's Crohn's disease, we actually see more perianal fistulizing Crohn's than just inflammatory Crohn's. And Monica, I'm sure you've seen your share of fistulizing Crohn's disease patients. That's one of the most devastating complications of Crohn's disease, right?
Yes.
And then we also see that South Asian patients living in Western countries are just in general at greater risk for all types of inflammatory bowel disease. That means not only Crohn's and ulcerative colitis, but remember, IBD is a spectrum. Some patients have a little bit of both, and we call that indeterminate colitis. As I mentioned, different ethnicities, Latin, Asian, Indian individuals may have more extensive disease progression than patients of other backgrounds. And this is a complete shift of what is published. This is different from the latest edition of textbooks of medicine that our medical students are learning. This is new data from the last 15, 20 years that's showing that these ethnic populations where we thought it was less common are actually more common than thought previously. And part of this, is because misclassification, right, of racial ethnic, subtypes, right? When we fill out little questionnaires or census, it does not capture how diverse people are and how they identify, right, and what their actual ethnic origin is. Notably, and this is seen across, many patients of color, they do have reduced access to IBD specialty care than their white counterparts. And we'll get into this more, but that makes us pause for concern. Why would that be, right? Why would they have less access? And it's not an easy answer. One of it's multifactorial, but part of it is decreased knowledge, right? The stigma of having a chronic illness and what that says about them, right? In South Asian culture, there's this concept of karma, okay? You did this, so you deserve that, right? You didn't listen to me, so you deserve that. You ate that, so you deserve this, right? So there's that karma aspect, which may present with, social stigmatization and shame. And there's also, the family unit often tries to deter, in some communities and families, deter Western meds, but might say, why don't you try this Ayurvedic supplement or this herb, or why don't you do a dietary restriction? What these things do, and I'm not saying there's no benefit to them. There's some exceptions that we can get into, but what this often does is it delays the access. And in the meantime, the disease smolders and gets worse. And now they're a sicker patient than when they were first having symptoms. And then they get in to see a specialist. Notably, another thing, and this is true just in general, this is not just unique to South Asian culture, but 40% of IBD patients at large, pun intended, are actually diagnosed with obesity. And we've really changed the way we think about obesity in general, but 40% are obese. And we don't normally think, I'm saying we as a whole, don't normally think of it as
smaller people, malnutrition.
Malnourished, right? We're thinking emaciated, right? Cachectic. But in reality, obesity you can be malnourished and be obese. You can not be nutritionally replete and be obese. And in fact, obesity is in and of itself a systemic inflammatory state of being. Their
Yes,
pro-inflammatory
absolutely.
cascade is upregulated.
Diabetes, the metabolic syndrome.
The metabolic syndrome, exactly. And now we bring it back to South Asians specifically with that lens. And we know that South Asians do have a
Yes.
significant prevalence of metabolic disease, coronary disease, high blood pressure, diabetes, or insulin resistance. So all of these little teaching points are really important when you're seeing that IBD patient before you.
Mhm. Fascinating. Fascinating. This could have been the whole session, but we've got so much more. So let's check back in with our patient and his case.
Yeah, so Dhanraj is he comes in, we get his vitals. His blood pressure is 135 over 92, so not quite ideal, a little up. His heart rate's 98. Maybe he's nervous to see me. Maybe he's dehydrated. Tall guy, 5'9", 230 pounds. BMI is 34. We know that BMI is not a perfect metric, but his BMI is quite elevated. So he would definitely be considered overweight. His primary care has tried to treat him with some antidiarrheals, right, to decrease the frequency of stools, has administered a low FODMAP diet and education, and has given some hemorrhoid treatment, which has not helped. Ultimately, he ends up in the ER, and there he reports to the ER team that he's having fatigue, palpitations, abdominal pain, and cramping. And Monica, do you guys use a lot of FODMAP dietary counseling in your guys' clinic when you see patients in general with GI symptoms?
We do not. Tell me about it.
So FODMAP, and this is why I ask, because some people are aware of FODMAP, some are not, but FODMAP stands for fermentable, that's the key word, oligosaccharide, disaccharide, monosaccharide, and polyols. A mouthful. But
Yes.
really a fancy way of saying fermentable foods,
Mm.
fermentable compounds.
Mhm.
And really, all of these are carbohydrates and complex sugars. And every food is made of these types of carbohydrates and sugars. There's no such thing as a zero FODMAP food.
Right.
And our gut is a big fermentation chamber, and
Yes.
our gut bacteria must digest the food and ferment it. And those byproducts can release gas and other substances that can cause loose stools or whatnot. And the bacteria must digest our food for us in order for humans to at all absorb that nutrition. If we didn't have gut bacteria, we were completely sterile gut, we would die because we literally rely on our gut bacteria to perform the early digestion, not just our proteases and enzymes. We need gut flora to digest it and break it up so we can absorb it. So some foods are really highly fermentable, some are not fermentable as much, and they can create a lot of bloat and gas. Now, FODMAP has a great use in patients who have irritable bowel syndrome, particularly with a bloating predominance or distended. So you can give them a low FODMAP regimen where you identify high FODMAPs, take them out like onions, garlic, cruciferous vegetables like broccoli, cauliflower.
Yes. Yes. So I've been doing that. I just didn't call it that.
There you go. And so, the running joke is we go get Mexican after this, and oh man, we know what's going to happen later, right? But everyone is sensitive to these things, and it's really useful in IBS. Now, it's brought up here because if this patient turns out to have IBD, we should know that up to 30 to 40% of IBD patients can have concomitant IBS. And bloating is a non-specific symptom, right? You can have it for a million reasons. It doesn't have to be from IBD. So there is some use. It's a restrictive diet, but it's not meant to be forever. If you restrict forever because you feel better on it, you're going to lose weight, be nutritionally depleted. So it's a temporary way of eating, but it's not meant for indefinite way of diet. And certainly the bleeding in the stools really doesn't go along with something totally benign like IBS.
Right. It's never benign.
Yeah.
It's not to have blood in your stool under any circumstances, really.
Yeah. Yeah.
That's always my take-home message. All righty. So yeah, everything is just so helpful that you're just a fountain of knowledge. So we're gonna loop back and ask the audience one more question. And this has to do with disparities in the treatment of IBD. So which of the following statements regarding disparities in the treatment of IBD is the most accurate? Is it A, patients born outside the US are more likely to be prescribed immunosuppressants and biologics? B, South Asians with ulcerative colitis are less likely to show a trend towards steroid dependence? C, Religion, cultural traditions, racial and caste discrimination, and socioeconomic status do not affect healthcare access or outcomes in patients with IBD? Or is it D, patients from underserved racial and ethnic populations experience more difficulty accessing specialists for IBD? We sort of showed our hand a little bit with our prior conversation.
Yeah.
And so for the audience, the answer is D. And so Nilanjan, I'm going to ask you to sort of maybe have a little bit briefer because we already talked about this a little bit, but discuss some of the data on the disparities in treatment in IBD and why D is the correct answer.
Absolutely. And so, I'm glad we discussed it early before getting to this question because it allows us to actually pause and then pick on some other points. I'm going to make light of this, but contrary to popular general stereotypes and beliefs, not all South Asians are doctors, lawyers, or engineers. And in fact, many fulfill all sorts of different jobs, non-traditional or traditional, whatever you might want to call it. I say that because sometimes this stereotype can actually work against
Yes.
someone who's perceived to be from that type of a culture that is stereotyped as high achieving, but not everyone is, not everyone can be, and that's okay. And I say that because that does not mean that all South Asians may have equal education or insight or literacy or even health literacy.
That's right. Two
And
different things.
yeah, right. And the other thing is when you see that South Asian patient, you want to get an assessment, right? In our case, Dhanraj is a very highly educated IT professional, right? But his health literacy may not be not so high. Most people may not have high health literacy, even if they're lawyers or physicists or
Exactly.
whatnot.
Exactly. I'm
So,
very literate, but I'm
yes,
only literate in the things that I know. Like
yes,
I can't do anything else. My taxes, I have zero tax,
definitely not taxes. Can't do that. Yeah.
zero literacy and everything else.
Yeah. And that's the I mean you're ahead of the curve because you're recognizing, right, that your patient may not be on the same page. And the other thing is all patients, not just South Asian patients, are very polite and maybe nodding their head, but they're being overwhelmed with anxiety and symptoms. Remember, he's a little almost tachycardic there. So he's not they may be listening to 10% of what you're asking and saying. So, we'll get into, language and communications, but you have to pause and ask them often, do you understand what I said? Do you have any questions? Can you repeat back what I said to
Yeah,
capture their attention?
exactly. The teach back method.
Teach back method. There you go. See, I didn't even know that's what it was called. So thank you. Um, the other part of this is, we recognize he has significant symptoms impacting his quality of life, and he's concerned about his employment. He may be concerned about how he provides for his family here and also back home. You also must understand that we're not just having a conversation with a patient, even though there might be one other person in the room. Oftentimes, in these communities, we're talking, the decision maker is not a patient clinician decision making. It's a physician clinician and a patient family unit.
Yes.
Whether they're standing in the room, I guarantee they're on the patient's shoulder or in their ear, and the patient's wondering, I got to talk to my family about that, or what will they think, and what, there are a million thoughts. And I think that's important because that can sometimes be what prevents that patient from taking the next step forward in terms of committing to a test or committing to a treatment or committing to a timely decision. Also, the last bullet point on the left was more worry about medication harm. In South Asian communities, there is a significant distrust. There's actually the paradox. There's significant respect for clinicians. They almost treat physicians as God back in the old country, but at the same time, there is a distrust of clinicians as well. So this paradox, right? Respect, but distrust. And in the West, when we come and immigrate here, that distrust is amplified with our Western culture. So recognize there might be distrust. Do you ever see that in your patients too, Monica?
Oh, absolutely. Yes. Yes. So much.
Yeah. And I think it's upon us, right, to try to engender that trust from the get-go, right? And say, hey, look, we're different. You can trust us. You can open up and talk to us. So,
absolutely. Every physician is a messenger, is a representative. And so we want to do our best to stand as a bridge between the rest of the physician population and the patients that we're seeing.
That's
Absolutely.
right. That's right. Another thing to understand here in this is that because of the South Asian culture and our access to homeopathic or Ayurvedic therapies, which is a reference to medicines of homeopathy, which are microdosing, you can say, of certain supplements to impart effective treatment, and then Ayurveda, which is I'm surmising it very quickly, but utilizing natural or herbal or alternative therapies to treat symptoms and disease. These are often pursued upfront, early, and oftentimes, well before a Western therapy or modern day therapy is initiated. And there are some exceptions in mild to moderate. You see high dose curcumin or turmeric.
Yes.
South Asians call it haldi, Haldi, with black pepper extract is a very effective alternative and in milder UC. Okay, there's good data for that. And there are other supplements we can talk about too, but sometimes that is not appropriate or enough to quench the fire in that gut. And so that leads to delayed access to the actual drug. Likewise, because of what I talked about earlier, karma and social stigma, nervousness, poor health literacy, sometimes their job, that they may not be the doctor or engineer, they may not have a job that gives them good healthcare insurance, or so they don't have good access to a GI. And one of the travesties that I think in our healthcare system today is we know we have a complete dearth of all clinicians. We have a complete lack of enough primary care and family medicine specialists for the population at large. And we don't have enough subspecialists to actually service on a population-based health scale all the patients that we have.
Right.
And so when you have niche care in an IBD specialist, not just a GI, the wait times to get in are even longer, right? Fortunately, the GIs that we see today, they're even better educated. Some of the ones who are attending this, they attend conferences, they're learning, they're hungry for this knowledge. And so you don't have to go to an IBD specialist to get this. But again, because we don't have enough GI specialists for the population at large, there's still a long wait time and delay to get in early when it matters the most. Some of the other teaching points on this slide are that South Asian patients do with UC seem to trend with higher rates of steroid dependence and also C. diff. Now, to break that up, having any form of IBD is an increased risk factor for C. diff without antibiotics. Without antibiotics, you can get it, and you're more likely to have recurrent or refractory C. diff. And as far as steroid dependence, we don't know why there's more steroid dependence, especially even if they have pancreatitis with mild disease. Is it, and this is a question, I don't know the answer, is it because there's a delay in care and a delay to effective therapy?
Right.
I think those are possible. And then, of course, we talked about throughout this, the cultural competency aspect. We're not recognizing that there may be barriers presented by the patient's immigration status, their gender, or even their religion that may prevent barriers too.
So lots of things, so many things to consider. So let's take it back to our case and pick up where we left off with learning some of the information about our patient.
Okay. So one of my favorite, if I have a favorite stool marker, I'm that guy who has a favorite test in IBD. It's calprotectin, stool calprotectin. Yes. Stool calprotectin is an inflammatory marker found in neutrophils. It's more sensitive for colonic disease than small intestinal disease. So it's very good for colonic disease. So great for a patient who has any type of Crohn's or ulcerative colitis. Normal's less than 50, elevated is more than 120. His is 400. It's elevated. It's not crazy. Crazy is like, significance like thousands. But it's elevated. You note that looking at his hemoglobin and iron indices, he has a severe microcytic anemia, hemoglobin 8, MCV 72, with a very low iron sat, 7%, and a ferritin at 12. So looking at World Health Organization criteria for men and women, this is severe iron deficiency anemia. He tells you he's got blood loss, visual blood loss, which might be contributing to it, but also IBD, just the inflammatory state of IBD actually presents with anemia of chronic disease. So you have high hepcidin, which downregulates ferroportin in the duodenum, so you're not absorbing iron. And so you end up becoming iron deficient. And that can happen even if you're not having more severe overt blood loss. So iron deficient. A CAT scan in the ER shows circumferential symmetrical wall thickening with fold enlargement. That is consistent with UC. And his subsequent colonoscopy shows that this gentleman has endoscopic findings that essentially show he's got Mayo 2 ulcerative proctosigmoiditis. And so we should entertain a discussion of all the different therapies now, but probably pause to check in with him before we go further into what kinds of